There we go.
Right.
Keith, you can actually just, for the intro of the video, it's nice when somebody explains what's actually going on.
Yeah.
So you could just do that.
And
Yeah.
then still M&D most predominantly here.
Today, we've got another group of student doctors, and we're just going to try and explain to them from a patient's perspective what it's like to get diagnosed with MND and how they can make the process better. Take one. Did they forewarn you about this?
Yeah, they did. They did. Yeah.
All right.
Are you the camera crew then?
Yeah,
Oh wow.
Yeah, so
I know.
some release forms. You guys are going to be on camera, right?
Yeah,
Yeah, I don't mind.
Yeah, okay, cool. I'll just give you these release
There's somebody should actually have given you the link to our vlog, because the last lot we did 2 weeks ago are already up,
Oh really?
so you get a chance to see how much involvement there is.
Yeah.
Now I'm told by little birdie that you're a bit more engaged than they are.
Okay.
You already think so, yeah.
Yeah. It was
No pressure then.
no.
Oh yeah, we're switched on.
It was. I mean,
Was it painful last time?
yeah, just a bit.
Yeah.
Kind of like, where's that tooth gone? There it is.
Oh dear.
But one of the difficulties with this is if you don't know, then you don't know to ask.
Yeah.
And it's the same when you started your first year. You didn't know half of what you know now, a quarter of what you know now. Now you'd know to ask, well, I've heard of that, but I don't know what it is.
Yeah.
Whereas back then, got a clue. So it's, I get that there's only 1 in 300 of us that get this disease.
Yeah.
It's not really rare, but it's rare enough that very few neurologists, virtually no GPs, are ever going to cross it in their career.
Yeah.
So I know that we're already making a dent in your experience over and above the experience of GPs that are now.
Yeah.
Because you've experienced, I mean, you're in one of the best M&D centres in the country, one of the top 5 in the world. So, have any of you worked with Dr. Boodman yet? No?
I've had him once for a dementia lecture.
The man's a genius.
Yeah, he was fantastic.
Yeah.
when I met him.
Dr. Shah, the respirologist,
No.
one of the most knowledgeable men I've come across.
Really?
He really is. If you can get on his service at any time, even if it's just for the odd shift,
Yeah.
oh, you'll learn so much. He's really good. Good thinking.
How long have you been doing this vlog for then?
But it's 4 weeks now.
Yeah, it's been
Yeah.
about a month now.
Oh wow. Are you doing it for any particular reason?
Because nobody else was. And I've got too much to say. So before I lose my voice, I thought, we'll get it said.
Yeah, definitely.
Right, are we okay to back up a bit, yeah?
Yeah, although I might escape for a little bit.
That's what you think.
You're not filming me.
Trapped.
I'm afraid you're already on. Give her a form.
Signed one last time.
Yeah.
Oh, you're okay. Good. Right, now, following on from what I was saying, there is no subject that's off the table. Whatever it is you want to ask, ask. Nothing offends. I'm going to die eventually. I'm just doing my damnedest to make it last as long as possible. If I live as long as Stephen Hawking, brilliant. If I'm gone next Christmas, I've done everything I can to prevent that. When you get a chance to look at the rest of the vlogs, you'll see there is nothing I've talked about or will be talking about. Dying wills, organ donation, tissue donation, care quality, elective suicide, anything's on the table. Doesn't matter what it is, if it comes across your mind, ask it. Okay? Now I'm told I'm supposed to let you ask questions each time. So,
Did you mention like how you were first diagnosed?
yeah, I started getting weakness in my right hand, and I'm predominantly right-handed.
Yeah.
Went to see the GP. He said, "Oh, it's arthritis." And then when it got worse, he said, "Oh, it's carpal tunnel syndrome." Meanwhile, 9 months had gone by, and it was old age. I'd had a previous spine injury, and my acupuncturist started to notice muscles changing in my back. And he recommended I go and see a specialist. Stood in front of a specialist OT, who immediately referred me to Dr. Boodman.
Right.
That was July 14. In July? No, that was July 13. I saw him, Dr. Boodman, the first time in November
Yeah.
at his Blackpool clinic. And he brought me into his ward here, 23, in January, and I was in for a week. The process was every kind of test you can imagine would have been done. A previous brain bleed meant that I couldn't have an MRI because it's got a stainless steel vascular clip on it.
Right, yeah.
They went through the other tests, a couple of spinal taps, and came up with the diagnosis of MND. As you know, there is no differential diagnosis. It's a case of eliminating everything else. One of the spinal taps was for polio, which is an often misdiagnosed result of the same symptom presentation. 5 to 10 on the Tuesday morning, before rounds, I was under the impression we were going to get a diagnosis of severe spinal trauma, lots of trapped nerves. You're going to have to have a cage and some sophisticated spinal surgery.
Yeah.
10 past, I was dying. And that's it. Within the space of 15 minutes, it was... And I actually thanked him, because like most people, my impression of motor neuron disease was Professor Hawking.
Yeah.
So I'm not going to die. I'm going to have a challenge in life, but I'm not going to die. Whereas with spinal surgery, that was a possibility. He left with his entourage at 10:15, straight on my phone. First thing that comes up, it's a terminal illness, you're going to die. Probably in about 14 months. Because my presentation was such that I could have been diagnosed 5, 6, 7 months earlier. So following on from 14 months from diagnosis means, well, actually, this isn't looking promising at all. And then within half an hour, have any of you worked with Pauline Gallagher yet? No?
No.
She's the M&D nurse specialist for Preston.
Okay.
And Amy and Sam are the nurse respirology team.
Right, yeah.
Within half an hour, they'd arrived at the bed with a bunch of nursing students, and suddenly there was hope. There was somewhere to go. There were things we could do to mitigate the symptoms. The NIV is the reason that I was diagnosed, by the way, in end of February 2014.
Right.
And the reason I'm still talking and walking and breathing unaided mostly is because of the way that this NIV was set up for me here. It's enabled me to expel virtually all the CO2 I need to. Every time they do a lung function test, the tissue is 100% ion. My diaphragmatic function is now down to 50%-ish. And yet, with that, I'm still able to talk and breathe and exist. When I'm not talking, I'm on the NIV. It's now about 22 hours a day. But it enables me to do this. It leaves me with enough diaphragmatic function to get enough air over the vocal cords to make a sound.
Yeah.
And that's the genesis of my arrival here from diagnosis. But much like yourselves, what year are you in, 3 or 4? 4. Much like yourselves 3 years ago, it would have been, what the hell is motor neuron disease? I've heard of it, but what does it mean? Well, that's how patients feel as well. Because however much awareness we do with the MNDA, we still to a degree are working in our own bubble. We're making people who are aware of MND more aware of MND. But people who are not aware of MND still don't have a clue. So yourselves and the other student doctors that I get to speak to hopefully will go away from here more aware of what it is and keener to look up the individual symptomology of the disease, because it's a lot easier to diagnose than we lead it to believe if you know what you're looking for. And if any of you are interested, the MNDA have got a red sheet. It's called a red sheet still, is it?
Red flag.
Red flag.
Tool, yeah.
You got given that this morning.
Yeah.
Right.
It looks really good.
Yeah.
Follow that, you'll get it right 90 times out of 100. And the other 10 times, it's Guillain-Barré. So you're not going to go wrong. Right. Next question.
I was just thinking when you were talking then, because you told us quite like a long timeline. Like how does it make you feel? Because I can only guess how I would feel.
You mean physically or emotionally?
No, emotionally.
I'm
sure it changes a lot.
When I was first diagnosed, I did fluctuate quite a bit because there's so much bogus information out there. You never know what you're reading.
Yeah.
Within kind of like 4 months, I'd already progressed down to a third-year biochemist because of the amount of research you do.
Yeah.
And then you realise, well, hang on a minute. It's a disease, just like cancer, just like psoriasis. It exists. I've got no more or less right than anybody else to get it. So start looking at what you can do to survive it. Because the more I researched about potential cures, therapies, treatments, none of which are available yet, but they're just around the corner. In clinical terms, that means 5 or 6 years, but they are literally just around the corner. There's 5 off the top of my head that are already in phase 3 patient trials.
Yeah.
So all I've got to do is stay alive, and that's what came through during that first 3-4 months.
Yeah. So within the first few months, that wasn't maybe your initial reaction?
No. My initial reaction, the first words out of my mouth were, I've worked so hard through my life. I've literally just retired. I've already travelled the world several times over. Had a great time doing it. But I've worked so hard for my retirement, and now I'm not going to get one.
Yeah.
And that kind of persisted for quite a while. It was really only once I'd got over that stage of, well, actually, I've invented a hashtag called Live Life Different. And that's kind of what I've learned to do. Just, it's not the retirement I planned, but then most people's retirement very rarely is what they planned.
Yeah.
This is just different.
Yeah.
And that, actually, that's the most poignant question anybody's ever asked me. That kind of got me from the depths of despair through to, well, actually, not only can I live my life different, but I can help others who are where I was get to where I am now. Just by, I hear so often, I'm going off topic a little bit here, but I so often when I'm on social media, I hear people say, oh, well, I couldn't tolerate the NIV. Neither could I. So Dr. Shah consultant sat down with me for an hour and a half in the middle of rounds and went through settings that I could tolerate until I learned to live with it. You'd be surprised what you can tolerate when your life depends on it, and when you're determined to get through that phase of this isn't going to be the rest of my life. My life's going to go on, and that was really the point at which I thought, well, how do I make this my life and not just my opinion? It's never a good thing when you make your life all about your disease. But with a disease like this, it kind of already is. Just learn to live with it, get through that initial devastation, and then figure out something that works for you. And that got me through that initial... I'm making it sound light. I know most people can't handle that. It's a terminal illness. It's not unlike most of the cancer diagnoses. Although 50% of cancer is curable, for 50% of the people it's not. So there are people going through a different form of this who learn to live with it. There are lots of us in the MNDA who are taking my approach and saying, well, okay, I'm going to survive this. If I don't, I'm going to have a hell of a lot of fun during the process. And that answers your other question, why? Why not? Nobody else is doing it. I can. I can talk the legs off a donkey. So I might as well. And then along came this opportunity to speak to professionals who are going to be at the pointy end of diagnosis. It's my opportunity to say, if you haven't chosen a specialist subject yet, this is it. This is the way forward. Because when we get a workable therapy or treatment for MND, we've cured Alzheimer's, Parkinson's, MS. Guillain-Barré is a 1 month cure process rather than a 9. Frontal temporal lobe dementia is gone because they're all based on the same faulty mRNA production process. So once you cure this, you've cured the most devastating diseases we have in society. Convinced? If there was ever a reason to get involved in neurology, that's it.
From your point, like for us three going forward, we might be dealing with people like yourself with MND or other life-limiting conditions. What would you say from your perspective are things that we as healthcare professionals often overlook, which are quite important?
Yeah. Emotional support. Make sure you know before you get to that bedside what you're going to tell the patient. Make sure there's a team following you to pick up the pieces. The overwhelming majority of people that get diagnosed get handed an MND brochure and bye, go and read about your death sentence now. I didn't get that. I got the brochure from Pauline and Sam at my bedside, who then spent a great deal of time with me going through what was going to happen, how we were going to deal with it. So whenever you diagnose anybody, make sure you've got a team coming in afterwards to clear up the mess. That's the best thing you can do. And understand that you can't get involved emotionally with the patient. You couldn't do your job properly if you did. But somebody has to. Somebody has to engage with that patient who, without wanting to blow my own trumpet, not all are as clinical about their diagnosis as I am. Most would get devastated and stay that way and would be inconsolable. So that support network has to come in quite rapidly. But when you're diagnosing a patient, it's oh so easy to follow your... I know they say you shouldn't use Latin anymore, and it's so easy to follow your Latin teaching when you're offering a diagnosis. Try not to, because I understood it when I was told, and there will be some that do. Most haven't got a clue. Most people who were diagnosed with MND, unless it's familial, don't even know what it is. However hard we work, the overwhelming majority of people who are diagnosed, it's the first time they've heard of it when you tell them. So having that support network behind you is key. And I'm sure that with the extra funding, with the extra funding that is coming through the pipeline for MND now, I'm sure there'll be an MND nurse specialist available more frequently outside of the specialist centres. But we've also got plans in place, or I have, to try and speak to OTs about doing this very same thing, and student nurses at UCLan, just to try and get more people aware of, if you're going to get people to accept, which is kind of what you were saying, this diagnosis is something other than an instant terminal illness, then you have to present them with options fairly quickly. It's kind of like you may all be too young to remember this, the brown bad news sandwich. Did you hear of that? You've got to give him the brown bad news sandwich. Gordon Brown. In order to give him bad news, they had to give him good news, then bad news, then good news. Because otherwise he'd go away depressed for the rest of the day, and they get no work out of him.
Right.
So that's kind of what you've got to do. You're not going to die. You've got MND. We have got things that we can do to help you, kind of thing.
Yeah.
Make sense?
Yeah.
Cool.
That just reminds me of something Dr. Boothman said. I don't know if you've got that off him or not.
No.
Not that particular, the bad news sandwich, but he said to us, I just remember the session, like, always leave the patient with something good at the end of the consultation.
Yeah.
No matter how bad something is, there is always something good in it, and if you leave them with all that bad stuff,
it doesn't take long.
I thought he was so right.
He is.
Yeah.
It works. It works brilliantly, because fundamentally, as human beings, we are like goldfish. 8 seconds, really? Yeah. So it's an excellent diagnostic tool. Just remember that your knowledge of this is always going to exceed your patient's knowledge, and so it should. But try not to make it sound that way when you're presenting. You're all intelligent guys. You'll recognise patients that can take on board a bit more information. But once you've gone with its terminal, the mind shuts off.
Yeah.
That's the point at which even a good news sandwich isn't going to help.
Have you always had your care in Preston?
Yes.
In this
Yeah. I live in Fleetwood, moving to Blackpool shortly into a adapted home. My GPs referred me to Blackpool, where Dr. Boothman had his clinic.
Yeah.
But yes, my care has always been through Preston, which is, as I said when we were in the other room, incredibly fortunate. It's one of the best MND centres in the world.
Have you met people from other
Yeah.
things? How does it compare? I don't know, just because I think Amy said this morning they have a really good team and quite a fortunate team here.
It's this is going to be seen by these teams, and I said it in each one of my vlogs so far, this is where the bar of excellence stands. Everybody else in the country has to drag their MND centres up to here. Some, it's appalling. And I don't normally name and shame because they're all trying to do a work. But some of the ones on the South Coast, in particular, around a recently promoted football team, for example, are abysmal. The level of service they offer their patients is appalling. The amount of information they give them, the amount of support. There are some that are seriously lacking. There are others, Stoke is a good example. They're not far behind Preston. But this is the centre of excellence of all the centres of excellence. So this is where they've all got to learn by. And it's not just Amy and her side, and Pauline and Sam and Dr. Boothman and Dr. Shah. It's Preston Wheelchair Services as well. I mean, they are second to none. I know this because I speak to dozens of people from every other wheelchair service who can't understand how I've got what I've got. And that's why part of what we're doing is to try and embarrass, if that's the right word, other services to come up to this standard. It's also to try and help other MND patients to know what is available. This is the gold standard. Demand it from their service. Demand it from their CCG. It's doable. We do it here.
Keith, I'm just conscious of time.
Yep.
Because we need to swap over, really.
Okay.
Do you guys feel like you've had enough time?
I could be here for hours.
Yeah.
Right. Let me just. You did something last time that I want to. Before we have a look at the NIV, how many of you have actually diagnosed a patient or seen the diagnosis of MND? No. None. So you know what guttering is? Cool, brilliant. Come hither. I'll show you what guttering is. Right. See that?
Yeah.
That's a clear sign of guttering. That's when the muscles in between the fingers and the metatarsal and the feet. What are these, Amy? Enterossei. That's a clear sign of MND. Very few other diseases have that, but when you see it, that's not a sign of carpal tunnel. You don't get that. It's not a sign of white finger or black finger. That's purely MND and other neurological conditions. That's good.
From quite early on.
Yeah.
Yeah.
The other things are when you get bulbar involvement. Now I can't really take this off, but when you get bulbar involvement, your jowls just drop down. That is a very difficult thing to see very early on. But when you do see it, it's another very clear sign. But that one's the one to look for. Chicken wings, when your bicep has pretty much gone, and mine has here, all that's left is the skin that used to come out to here on my guns is now down here.
Yeah.
And the other one, I'll lift this up so you can see, actually, the other leg.
Do you need a hand?
No.
Oh, yeah.
Yeah? That is a sign of a calf going. Now that, again, all the muscle that used to be there used to fill that up.
Yeah.
I was a sportsman, by the way. So when you start to see things like that, that should pique your interest.
Yeah.
And then you can go through the, what's it called again? Red
flag.
flag.
So the red, yeah.
Yeah, when you see things like this, that should trigger, I need to look at this a bit closer. And then you can start doing your other diagnostic tools to investigate. But remember, most of them are incredibly uncomfortable. We're doing stuff about the the what's it called, Amy? Sticking the pins in with the electric.
Yeah, so we're looking at whether we can use ultrasound as opposed to invasive needling techniques to look for evidence of.
She knows what she's doing.
So talks not recently because you can actually. It's like the same thing as when you're pregnant, isn't it?
Well,
You
yeah.
actually see the.
We're in the middle of doing a documentary about it.
Okay, cool.
The team from MNU.
Yeah.
We filmed my study session last week.
Right.
We're putting that together. We're going down to MMU to film Emma and her team and their lab and kind of show what that's all about.
Oh, brilliant.
So,
Yeah.
right, do you want to hand me up the NIV and I'll
Let's have a quick go. Just borrow that test.
Yeah, of course. Yeah, go on. Swap over.
So have you been on using the NIV from quite an early
Yeah,
stage?
I was diagnosed the end of February and I walked out with that after my diagnosis.
And is that because your diagnosis took quite a long time? That you
No, it's because I've got an excellent team. Really, it is. Most people also choose to wait instead of taking it on straight away. Now, you'll hear a change in man.
ones rather than the
Yeah, I use this during the day. Ready? And that's it. That's taken all the CO2 out of the bottom of the lungs, out of the alveoli, and now I can fill it with oxygen again. CO2 is bigger than oxygen, takes up more space. Oxygen can't dissolve into the blood. Now I can get a full breath in, and my voice is much clearer and much louder. And it's as simple as that. Once you know what you're doing with it, it really is as simple as a couple of breaths can clear your lungs back out again. It doesn't have any effect on the diaphragm. I need a full face mask to actually take the pressure off the diaphragm. But this does a job.
And you said you've been use that 22 hours a day, is that right?
Yeah, I'm on this one for about 14, and my full face mask when I sleep.
right.
How long were you on it for when you first got it? How many
Just at night. We first tried this out because when they did a Tosca, it seems there was about 44 apnea incidents through the night and only got 3 hours sleep. So this was an alternative to waking up every 15 seconds to take a breath. It solved that problem, and coincidentally has meant that my diaphragm has been under less pressure. So this just that's it. Good. This just enables me to get thank you. To get a clear out of the system during the day when I'm on it. It just enables me literally to not think about my breathing. The little bit of breath I take in, that forces the extra 2 litres, is it?
Something like that.
Yeah. The extra 2 litres into the bottom of the lungs. It works in reverse. Your diaphragm sucks air in that starts at the bottom and then fills up. That starts at the top and fills down. So it's a technique you've got to learn, but once you've learnt it as a patient, if ever you come across a patient who says I can't tolerate it, slap them around the head and make them. It will keep them alive longer.
Or show them this
Right,
video.
on that note, I am going to have to pluck them.
Yeah,
Really
yeah,
sorry,
sure,
'cause
it's
I know-
okay.
I know you're
Yeah,
at
Thanks very much, guys.
Can you
Thank
just move
you.
forwards for a shot?
Yeah.
Might just leave the door open so I'll keep for a minute or two while I go and get the others.
Okie dokie.
Ventilate it.
Yeah, it's a bit hot, isn't it?
I'll be about 5 minutes. Okay.
Thanks ever so much.
Pleasure.
All the best.
Thank you.
We'll get you a link to the vlog so you can have a look at it.
that'd be good.
Thank you very much for your time.
Pleasure, thank you.
Bye.